My name is Erasmus Taylor, and I welcome you to the session. This is SWACCS. This is SWACCS, Statewide Anesthesia and Critical Care Seminars, and we are handling pulmonary madness. This is brought to you by the Government of Uganda and the Society of Uganda, and we are available on the different social media channels. You can review information relevant to the sessions as well as the previous recordings of the seminars. Welcome to the session. But first, is a review of what happened last week. Last week we covered episode 7 of the series, and that was focused on bugs and the lung. That was the microbiology, and had a clinical case presented by Dr. Semakula, followed by a chat on inflammation and acquired pneumonia by Dr. Charles Nkuko, Dr. Nakinji, collaborating consultant from internal medicine, and Dr. Bridges took us through the bugs, HIV, and the lung. And finally, we had an explosive conversation on pharmacology, ICU, particularly antimicrobial therapies in lung infections, delivered by a clinical pharmacist, Dr. Daniel Chance Mwanda. That was quite a long session, quite rich as well, and the recordings can be found in the links to our YouTube channel provided. You are free to find a lot of information on that site, and also deliver to us any feedback that you think you can use to improve the sessions. Dr. Cornelia Sendagire was a mentor for last week, and basically the main take-home point of feedback, on top of so many things discussed, pneumonia is related to sepsis. We have all the blood, the cardiovascular lung, and therefore an infection in the lungs should most likely get washed with different tissues. And that is really why people get lung infection and like to go into profound disease of sepsis and microbial involvement quicker than patients who get involved in other areas. The diverse microbiology of the lung, and we also got highlighted to a possibility of that interaction between the normal fluoride of that and so this was a fun subject that was touched, and hopefully people will switch for study. The key thing is that the diverse possibilities, diverse therapies available, and our job in ICU is to identify people who need help quickly and proceed to provide support, diagnosis, treatment, and prevent the conditions that could potentially deteriorate. HIV has not left us, it's still in the game and still changing the ballgame of most participants in the critical care setting with lung infections, and definitely also extending beyond that to non-infectious complications in the ICU. And really it's quite interesting to understand what we can do even if it's to appear immunocompetent. Finally, pharmacology in this case is relatively older, and the choices of antimicrobials vary as well. So that was really a key conversation we had last week, which fits into today's conversation. Today we are on episode 8, which is covering specialty diagnostic consult. And this is really trying to see where other consultants, other specialists in helping us decipher what is happening with our patients. When you should complete the call, what falls in the brain to your fight, say patients, the ICU, and how soon you should utilize them. Let's pay attention and listen to this panel of presenters. We shall have a clinical case followed by a chat on microbiology, and then radiology, and finally we shall go into pulmonary endoscopy. These days are all good guns, and so there's no one to mentor them. we are actually getting mentored. So Dr. Cornelius and myself will be the moderators. So as usual, our rules still again, make sure you're muted. Share your questions on the chat and raise your hand for a chance to speak when the chat is open for your questions. So over to the very first presenter, Dr. Maria, who's the university resident of the university, to be diagnostic clinical patient today. So over to you, Doctor. Kindly share your slides.
Thank you, Dr. Erasmus. I will be sharing my presentation in a few. Good evening, everyone. I hope you're able to see my presentation.
Your presentation is very clear, and you can hear it very well.
Yes, Dr. Erasmus, can I go ahead?
Go ahead, please. Can hear you.
Yes. All right, thank you. So the case I'm going to be presenting is of a 64-year-old male that was referred from Mbara regional referral due to having cough for 3 weeks and then also worsening difficulty in breathing. He was a known ISS that was on ART and was diagnosed with acute respiratory distress syndrome, ruling out PJP and PTB. On admission to the critical care unit, he was admitted through the accident and emergency. He came in respiratory distress with very high respiratory rates, tachycardic, and also having very high oxygen requirements. And he was very anxious with hyperalbuminemia and then also electrolyte imbalances. So at that time, in admission to the critical care unit, he had a GCS of 15 out of 15. The pupils were both econ reactive to light, about 4 millimeters each. He was not sedated and he wasn't on any anticonvulsant. Respiratory-wise, he had a respiratory rate of up to 32 breaths per minute on a non-rebreather mask and saturations of 95% at up to 15 liters of oxygen. He had widespread crepitations everywhere in all the lung fields with reduced air entry in the lung bases. He was being nebulized with Combivent and a baseline ABG was done that showed the FiO2 of 0.7. This was while at emergency. pH was 7.4. PO2 was 57. PCO2 was 36.4. Bicarb of 25.9. A base excess of I think 1.4, and then a lactate of 2.3. He had a chest radiograph that was done that had shown features of ARDS. Basically, he had very small lung tissue that was remaining on the chest X-ray. And then an HRCT was done that also showed ground glass appearance. And gene expert was done that was negative. However, he had already been initiated on anti-TB prior to transfer into the unit. Cardiovascular-wise, he was hemodynamically stable, and at the emergency, he had heart rates of up to 95, but these heart rates would go up to 130. And then blood pressures of 116/80, MAPS of 88, capillary fill of less than 3 seconds, and warm peripheries. He was hemodynamically supported, not supported, and then also he wasn't taking any antihypertensive. An echocardiogram was done, and it showed dilated right cardiac chambers, moderate pulmonary hypertension with an incomplete right bundle branch block. In the GI, he was feeding orally on demand and opening bowel, and then he was also on rabeprazole, and albumin was started. However, he wasn't on any prokinetics. In the genitourinary, he had an adequate urine output of about 63 mils per hour. That at kilogram body weight of 70 kgs was about 0.8 mils per kg per hour. And he wasn't on any diuretics. And by the end of the first day in the unit, he had a positive balance of up to 1 liter. He had a urine catheter that was draining clear urine and normal renal function tests with a creatinine of 73 and a urea of 6.4. Both potassium was in normal range at 4.35 with a hyponatremia of 130, and then also chloride of 98. He was not being dialyzed, and the sodium was being replaced with sodium chloride tablets. On infection-wise, he had no fevers, according to the history prior to transfer into the unit. And also, while in the unit, in the initial days in the unit, he had no fevers. The highest temperatures being recorded at about 36.1, white cell counts of 9.15, an HB of 14.6, and a platelet count of 218. The CRP was elevated at 256, and also a procalcitonin of 7.9. He had no pressure sores, and he was on antibiotics, PISA, Septrin, azithromycin, and on RHZE for TB with pyridoxine. For analgesia, I was receiving paracetamol and Clexane 40 milligrams subcutaneous for thromboprophylaxis. While in the unit, he didn't stay with us for so long. However, by the second day in the unit, his oxygen requirements, he developed quite a number of complications while he was in the unit, but mainly these complications were respiratory. And by the second day into the unit, his oxygen requirements had increased. And so we had to transition him from the non-rebreather mask to a CPAP mask. For which, again, he didn't tolerate well because his respiratory rates were still going up to 45, sometimes even readings of 50. He was very dyspneic. And for this, we transitioned him we intubated him and put him on mechanical ventilation. So he was started on while on mechanical ventilation, it was quite difficult to mechanically ventilate on those on the days while he was still on mechanical ventilation, and various modes were utilized for mechanical ventilation to include mainly pressure modes and also PRVC, which was giving us at least some adequate tidal volumes. However, to ventilate him too, a rocuronium infusion was started, and sedation was obtained with fentanyl, midazolam, and dexmedetomidine infusions to achieve a RASS of about -2 to -3. However, we still were ventilating him and achieving very high peak pressures of as high as 47. And also while in the unit, the following day after intubation, he accidentally self-extubated and so was reintubated again. Then within 24 hours of those events, he also developed a subcutaneous emphysema. While in the unit after the reintubation incident, he developed a subcutaneous emphysema. And at this point, CTS was consulted and helped with the management of the subcutaneous emphysema. However, still peak pressures remained high. And then also we noted that he was having bloody secretions in the ETT. And at that point, also ENT was requested for consult, for which they had advised to do a bronchoscopy for the patient. However, a few days, about one day with the subcutaneous emphysema, the patient also started becoming rather more hypoxic and harder to ventilate too. And the SATs were basically about 90 to 90, and then reducing up to even 77 over the course of the next day. That's about day 5 for him. So he also developed hypotension, but this was about day 3 following the intubation. He developed hypotension, and he had been supported by noradrenaline and epinephrine infusions to maintain a MAP of up to 65. The target MAP, we're targeting at least MAPs of 65. And then hematology-wise, initially he didn't have a thrombocytopenia, but while in the unit, he also started developing a thrombocytopenia. And then other systems had no complications. CNS, he was still being sedated, still requiring a lot of sedation to require the target RAS. And then also GI, he was feeding via an NG tube, and he was tolerating his feeds quite well. So on following him up, still that's on day 5, the hypoxia worsened, and at that point, saturations would not go above 85. And sadly, the bronchoscopy was not done because it was scheduled a few days after the initial review for the patient. And then a couple of multiple investigations were also requested, but most of them we didn't get blood workup back, like blood culture and sensitivity. All those were not done. Yes, however, sadly, the patient passed on after staying with us for a few days. May he so rest in peace.
Thank you so much, Dr.
Thank
Senior.
you.
Thank you so much for this presentation. Ending quite a lot of work, quite a busy patient as well, in terms of what's going on. So I would like to open the chat for questions. Kindly raise your hand or send your question for chat and we'll pick you up. At the moment, I don't see any questions. So maybe if I could ask, just in case anyone missed, this patient was suspected to have in PVT. What case specifically was sent to Philippines?
Pardon?
This patient was admitted with suspicion of PVT ARDS.
Yes.
Which case sent for that specifically?
Yes. So the patient was admitted with a diagnosis of ARDS, and then they were also ruling out PTB, but PTB was basically a radiological diagnosis for him, but the gene expert was negative. And yeah, so it was the anti-TBs had already been initiated prior to admitting the patient. So we continued with the anti-TB.
Yes, but there was a differential of PVT.
Yes, also that was also a possible diagnosis for him. That was among the diagnoses that were listed for him.
Yes, but how was that? Was that confirmed by the diagnostic test?
No.
Okay, all right, thank you. Dr. Timwe, your hand is up.
Hi, thank you, Dr. Maria, for the presentation. I wanted to ask about the emphysema. You didn't clarify, did you figure out the cause of the emphysema, and what did CTS do? You said CTS managed. What exactly did they do for the patient? Thank you.
So when CTS came, of course, we didn't necessarily put in a chest tube for him, but we sort of poked the chest wall, and that would release the pressure. Yeah, but we didn't insert any chest tubes or, yeah.
Was this first to be coming from a pneumothorax or pneumomediastinum? What was exactly the diagnosis?
Pardon?
Was the emphysema thought to be coming from, was it thought to be coming from a pneumothorax or a pneumomediastinum? Well, what was the source?
So we didn't get to know the source of the emphysema, and we thought that's why we had asked ENT to come and do a bronchoscopy and probably tell us. But one of the things that we thought about was probably the patient might have injured the airway while they self-extubated accidentally.
Okay. Was a CT scan considered, perhaps, to analyze that? Because in the setting of subcutaneous emphysema, it might be difficult to assess for using chest X-ray, for example, or even an ultrasound.
Yeah, so Also, most importantly, we had radiology requested, but the chain of events was quite rather fast, and the patient was very unstable. Yeah, in those remaining days.
All right. Any other questions? Dr. Cornelius?
No questions from me.
All right. Okay. Thank you very, very much, Dr. Maria. So with this case in mind, we will be making references to it as we cover the remaining topics. So thank you, Dr. Maria. So I would like to move to the next speaker of the day. So Dr. Paul Katongole is a clinical microbiologist and lecturer in the Department of Microbiology at Macquarie University. He is going to take us through matters through the microbiological diagnosis of lung disease. So microbiology sample specimen collection and analysis. Dr. kindly share your slides. In the meantime, Dr. Asimwe, Maria, could you just give us a quick summary of the case presented?
All right. So in summary, the patient I've just presented was a 64-year-old male that was admitted and being managed for ARDS, ruling out PJP and PTB. Yes, with worsening hypoxia and yes, worsening hypoxia. Sorry.
Perhaps with a complicated in hospital stay. So yeah, we will get you to do a bit of the summaries now of the fact to help colleagues catch up with the previous repeater. Yeah, we are going to be responding some of the questions on the chat. I think Dr. Bitsakan is asking how was CJP rolled out. I did ask some question, but it appears this was not concluded. But the patient was empirical.
Yeah, all right.
All right, so some of the questions please keep on coming for the case that we just handled. But yes, as I introduced already, Dr. Paul Katongole is a clinical microbiologist at Macquarie University and is going to take us through respiratory specimens, collection, transmission, and processing. So as usual, we know our ground rules. So Dr., take it away.
All right. Thank you so much, Dr. Rasmus, for coordinating this, and good evening, everyone on this meeting that we're going to have. So we'll go through understanding the processes of collection, transportation, and processing of respiratory specimens. I've tried to make sure that I pick out the most clinically relevant components of the work and not to go so much into the detail of the laboratory processing activities, things that clinicians need to actually know, and also understanding of some of the basics in the lab that happen. So important to note is that laboratory results will always depend on the quality of the specimen collected and the processes of delivering that specimen to the lab and the environment in which all this happens. So the quality of the results will actually depend on those processes. And in the lab, we call these the pre-analytical processes, the things that happen before the sample reaches the lab. They will actually be very, very critical. It's also important that the labs create a good working relationship with the clinical team they support, because this relationship enhances the sharing of knowledge and sharing of the results and interventions that help in ensuring that patients actually get quick support for improvement in care, especially for results that involve getting feedback within different times and days, because a couple of samples in the lab will require to get preliminary results like 24 hours, and then you might need to get more results as time continues, because especially culturing, some of the results keep coming in piecemeal. Then clinicians should be provided with reference manuals that will help them understand things like what is the right specimen type that should be collected. If there are volumes involved, what is the right volume for that kind of sample? What are the collection sites? What are the proper transport media or transportation temperature? How do you properly label these samples while they're coming to the lab, and the storage? And these are important because then they will help reduce on the rejection of the samples, but also they help the people in the lab to understand what exactly they are dealing with. Because I'll give you an example. If you bring in a patient who has come in and this patient is maybe from the ICU, and you bring in maybe a catheter tip sample, but then on the form, the only thing you're saying culture and sensitivity, you're not even indicating that this patient is in ICU, it might actually lead to delay in understanding how critical this result would be to report back immediately. Whereas if someone knows that this is actually coming from a high dependence unit, they'll even first call you back and give you the results of the gram staining to help you even in initial phases of the treatment as the cultures come out in the subsequent days. So that kind of communication is important, but also understanding by utilization of reference manuals on how best to do some of the things. So what are the common specimen types that are normally used when we're dealing with specimens? The most common are two, which are basically sputum. And then we have the bronchoalveolar lavage, which also comes close to what the bronchial wash and others. We also have the tracheal aspirates. Here are some of the common samples for respiratory specimens. So we'll talk about mainly the two of them, which is sputum and the bile. You will notice that some of the things between these two, especially in the lab, at the level of processing, tend to resemble, but certain things are a bit different, especially in the early phases of processing of the samples. So sputum can either be expirated or induced. When you're inducing, of course, we all know that you have to use hypertonic saline to induce the sputum, but the most common sample is the expectorated sample. This is the common one where we just tell the patient to cough deeply and then you will produce a sputum. So recommended quality is often the thick, either mucoid or mucopurulent material between 2 to 5 mils as the recommended material. And poor quality specimens are those that are thin, watery, salivary, and attain nasal secretions. And these are often unacceptable and they should be rejected. So we'll talk about this a bit later, where we often, as we're processing these samples, we have to look at the number of the squamous epithelial cells under the low power microscope to see how many they are. And depending on how many these squamous epithelial cells are, it determines whether we actually accept the sample or we reject this sample. But this criteria oftentimes does not work for induced sputum samples, because we believe that these induced sputum samples are gotten deep from the lower part of the respiratory tract, which is often a bit less non-sterile or less contaminated with oral flora, unlike the expectorated sputum. So oftentimes when the sputum sample comes in and is labeled induced, it's important the lab knows, and even when it's not as mucoid, they give it an allowance to be processed. So oftentimes the container used is a leak-proof plastic sterile container, and always while it's doing all these procedures, we should be able to practice airborne precautions when collecting the sputum, because the process is aerosol generating. And if you think the patient that you're working on, you suspect TB, so you'll need to use a respirator. Most of the common respirators in our market are the N95 masks to avoid contracting TB. And the samples should be transported to the lab as soon as possible, preferably within 2 hours at 2 to 4 degrees centigrade. And this normally requires a cool box or cool a cooler system where we normally use ice packs, and then we move these samples straight to the lab. And if this is not done immediately, then you need to create some bit of storage at the facility where you have it, where you need a freezer or a fridge for the couple that day, but always recommended to avoid batching of these samples. At least ensure that within 24 hours, the samples are transported to the lab. So what are some of the rejection criteria for the sputum samples that are collected? The specimen might be in a broken or damaged or leaking container that could lead to sample being rejected. If the container is inappropriate, if the specimen is not well labeled or there's not enough information in the container to match the paperwork, that could also lead to rejection. If the paperwork does not match the sample, or if the samples are visibly having saliva, so that could also lead to rejection. So processing of these samples, when we processing sputum samples, we start with what we call macroscopy. This is the things you can actually see visibly. You know, the amount of the sputum, the consistency, the color. Is it mucoid? Is it purulent? Is it blood stained? And all the other things. Then of course, we go after that and look at the gram staining. Now, under gram staining, you often make a smear, picking the most purulent or mucoid part of the sputum and make a smear on the slide and examine this under a low power by looking at 10 to 20 fields of the smear to determine the average number of the squamous epithelial cells per field. And then after that, you can also examine the number of leukocytes, and then you record by saying +1, +2, +3, +4, as we shall see later. And if you look at this table down, it shows you that if, for example, you have less than 10 polymorphonuclear cells under low power, and less than 10 also squamous epithelial cells, this sample should not be accepted. If you have more 10 to 25 polymorphonuclear cells and less than 10 squamous, then you accept that sample, and above, as you see the different figures in there. So that helps you to actually determine which, because ideally the squamous epithelial cells are indicator of more of saliva than actually the actual mucus that comes from the lung. So this is just a picture trying to show us how some of the different samples look like: the thick mucopurulent, the watery one, the salivary, the blood stained samples. So still, after examining the slides, you need to examine for presence of the predominant pathogenic bacteria. It's also routine that a ZN stain is conducted for all samples, and then you look for FBs. And after this, of course, it's important that in case of any signs of FBs, then you go ahead and maybe do gene expert if you suspect that there is TB. The sputum for pathogenic bacteria or fungi, you inoculate this onto basically blade agar, chocolate, and maconche agar while targeting bacterial pathogens. And if fungal hyphae or yeast cells are seen while doing a gram staining, it's recommended that the sample is inoculated on subaroid agar and do a fungal culture. And in case of culture for mycobacteria is requested, then that sample should be moved to the TB lab, where there are standard precautions that are instituted for TB cultures, where you have negative pressure rooms, where you have to institute more work using high-level biosafety cabinets, or you just want to do simple gene expert that you can actually get within an hour to have results. So while you examine the place for growth of suggestive organisms, these are some of the common pathogens that are often associated with lung infections in sputum. We have the probable and the possible pathogens. Now, probable and possible pathogen, this here means that probable pathogens, if these are probable pathogens, if the pathogens growth is greater than 2+, as we saw previously, and possible respiratory pathogens, if more than 2+ and predominant. So oftentimes you will notice that we see more than one pathogen happening where you have a polymicrobial picture. So these are some of the possible organisms, but also it's important that we look out for these and report them accordingly. So the most common one that normally we have are strep pneumoniae. Oftentimes we have influenza, Haemophilus influenzae. Then oftentimes when patients have been on the ward for long, when maybe it's a nosocomial infection, you can find Pseudomonas coming in. And then oftentimes you can find patients actually having lung infection that are associated with fungi and other possible pathogens, including Cryptococcus neoformans. You can actually have Aspergillus and many other kind of lung infections that are not necessarily bacteria. And also you can have other possible pathogens. Now, these oftentimes why they are called possible, because at times they can be contaminants. So for you to say they're actually pathogens, they need to be predominant and they're greater than 2+ and they exist in large numbers. So after identifying the organism, by of course doing a basic laboratory biochemical tests and ensure this is the bacteria that you've actually identified in the lab, then of course you go ahead to conduct microbial susceptibility testing using standard laboratory guidelines, but oftentimes in Uganda we follow the international CLSI guidelines to actually determine the zonal diameters and all the susceptibilities for the different organisms. And it's also important that each lab is able to conduct quality control for all media, reagents, and everything they use routinely following their standard SOPs. This ensures that the processes are actually working out and everything is followed according to the standards. So how you report the sputum sample results, of course, as you write the results report, you need to talk about the macroscopic appearance. How was it appearing? Was it a blood stain sample? Was it micropurulent? Was it a purulent sample? Then you list the gram stain characteristics. What did you see on the gram stain? Were they gram negative rods? How did they were they pin-like appearance? What were the way they show in terms of characteristics? Then you need to actually tell us that you did a ZN and there were no FBs seen. Even though it's negative, you need to indicate that, because then at least the clinician is sure that this was done and TB is one of the things on the lower side. Then the culture results need to be presented. You report the quantification of the significant pathogens that you saw and their susceptibility profiles. And in case of growth of only normal flora present, then you need to report and say growth of normal flora of the upper respiratory tract. Oftentimes, when it's normal flora only present, we don't mention the organs, we just say growth of normal flora respiratory tract. So when we leave the sputum samples and we talk about BAL, bronchoalveolar lavage, here there are some similarities, but also different things that happen. BAL samples are often collected from patients not able to spontaneously expectorate sputum and increase the chances of them detecting pathogens, especially in the lower parts of the respiratory tract. And this is often done following bronchoscopy procedures. And the procedure is very highly among the high aerosol generating procedures, and so requires stringent measures of airborne precautions, especially use of N95 masks and everything that is involved. So BAL samples should always be processed and avoid rejection. If any rejection is going to happen, it often should be done in proper consultation with the clinician that send the samples. So all samples must be processed in the biosafety cabinet, and samples should be first centrifuged, and only the sediment of the sample is used for culturing. So this is briefly about the procedure of doing the BAL, where you use the bronchoscopy and then it has a camera Most of you here are more knowledgeable in the procedure than me, so I will not go back detail into this of how exactly the procedure is done, but we know it most of the times done while conducting a bronchoscopy procedure. So when we look at some of the different samples that are non-respiratory samples but non-sputum, we said we have the BAL, we have the broncho brush or washing, which is very similar to BAL, then with the endotracheal aspirate and transtracheal aspirates. The collection here, basically correct washing or aspirate in the sputum tap. You place the brush in a sterile leak-proof container. Minimum volume, as I said earlier, still the same, up to around 3 mils. So around 3 to 5 mils. Transportation should be at room temperature as soon as possible. If transport is delayed more than 1 hour, refrigerate. So the principles are more or less the same, even for sputum, to ensure that the sample is transported as soon as possible. If there is delay, you need to refrigerate at 2 to 4 degrees before the sample reaches the lab. So processing. So of course, we still do a gram staining and look for presence or absence of squamous epithelial cells, presence of fast cells, open polynuclear cells, also the presence of bacterial fungal elements. We do ZN smears for FBs, intubate still the same kind of media, which is blood agar, chocolate, and maconche. Why we use several media is because we are targeting different organisms. Some of these media are able to actually detect media like chocolate are highly selective media, so they will be able to select certain organisms in the maconche, and especially chocolate is also an enriched media, so to be able to detect certain organisms like Haemophilus that could not easily grow on agar like blood agar. So in case also we suspect a fungal infection, it's important that we use sabodextrose agar and intubate at 35 to 37 for 18 to 24 hours. But if you actually expecting a fungal pathogen, the intubation period can go up to 14 days. But for bacterial specimen, we often intubate and keep checking up to 72 hours. And then we perform culture sensitivity using the CLSI guidelines. And for the BAL samples, we look at for significant bacteria quantities, and significant bacteria quantities are those that are at 10 to the power 4 in number and above. Below that, that is not significant. And so this table tries to show us the number of colonies seen. If you see less than 10 colonies seen, colony forming units per, the colony forming units per mil will be less than 10 to the power 3. If you see 10 per 100 per field, this is 10 to the power 3 to 10 to the power 4. Greater than 10, greater than 100 colonies per field, that means you have 10 to the power 4, 10 to the power 5. So that helps you to determine significance of the bacteria in the sample. So you examine the plates for significant growth and quantify each colony type according to the table above. The diagnostic threshold is greater or equal to 10 to the power 4 colony forming units per mil. However, this might not be met if the infection has just started or if the patient has been on antibiotics, because this affects the growth of the organisms in the sample. So that information could be needed, especially if you're sending in a sample. It's important to say that the patient has been on antibiotics for maybe 2 days or something. That could actually help, and also calls for actually discussing between the different sides, the lab and the clinicians. So pathogens are still the same, the lung pathogens, as we talked about earlier. And here we are saying that if you are able to see filamentous fungi, please follow up this in a mycology lab and be able to culture it and identify it effectively. So reporting, of course, we report no growth of bacteria if there is no growth after 72 hours. If growth is greater than 10 to the power 4 chronic units per mil, report as significant, report the organism itself and its sensitivity. If growth is less than 10 to the power 4, report isolated organism, quantify with a comment. However, it may not be met if the infection has just started as said. So here you still report, but also make a comment and say the diagnostic threshold is this, but that you have a discussion with the clinician to see how best to follow up this patient. Filamentous fungi isolated, identification to follow, should be followed up to 14 days of culturing. The type of organ isolated with a susceptibility profile should be also reported. So we'll stop here, and I would like to thank you all.
Excellent. Thank you very much, Dr. Katongole. Yeah, we've got a few questions so far, but I'd like to invite more questions here on the chat where you can raise your hand. So pick ones on the chat, Dr. We would like to understand what the current stand in microbiology is on the practice of culturing catheter tips. Previously, in our training, even in our practice, we've been sending off urinary catheter tips in people with suspect of UTIs, and also central line tip, among other things. In fact, at some point, I don't know, something changed, that I changed or whatever. People were sending off ETT when they exclude the patient, and it looks like the test code that, you know, that big Uber and gooey stuff on it, so they'll cut it and look at this tube and send out. So I wish to get your comment on that before we get another question. Over to you.
So before I answer, I need to be clear. The sound was a bit muzzled. Are you saying what's my take on culturing of catheter tips for both central line and peripheral line?
Correct. You've been doing central line catheter tip cultures, urinary catheter, tip cultures, as well as ETT tip cultures over time. So is there a current guidance that you can offer us on the safety and reliability of this? Thank you.
Yes, the guidance actually is there. And the reason why actually we didn't talk about this here is because the discussion of catheter tips often comes in when we're talking about bloodstream infections. That's why it normally comes in, because most of them, especially the one for the central line, they discussed under bloodstream infections. Then the one for urinary catheters are discussed when you talk about catheterized urinary tract infections. But the guidance is that oftentimes, yes, the catheter tips can be cultured, but there's a criteria in which you should be able to accept whether what you've actually cultured is a pathogen. And oftentimes when you're culturing these catheter tips, it's often recommended that at the same time you do a blood culture and you compare the results for both the catheter tip and the blood culture. And at times when there is concurrence, then you actually know that this is the same organism that actually is able to cause the bloodstream infection. But also it could also be an organism that's not seen in the blood, but still providing certain kind of symptom. Then you actually, there's another criteria in which you can use to accept whether this organism is actually pathogenic. And also there are ways of managing this through utilization of certain antibiotics. Some are a bit topical and others can be used intravenously. But there is a whole standard criteria that is used for catheter tips. The same is for the urinary catheters. Those oftentimes there is a proper procedure of making sure that they are removed very well, and then they used to get the culture sample, and then insert a fresh catheter when you're going to do when you're going to do culture. That is a recommendation for urine cultures. Normally you have to first remove the catheter that is probably causing the infection, and then insert another one, then you use that catheter to actually get a sample, and then you do the culturing. And of course, after that, for the urine, of course, there's a criteria. Urine has a bit of also using quantification of the colon-forming units, whereas a normal urine sample, which is a midstream clean cut sample, the quantification is of significant bacteria is 10 to the power 5 and above. For a urinary catheter, it's lower, it's around 10 to the power 3 to 10 to the power 4 to actually accept it as a significant bacteria.
Thank you very much, Dr. Rio. And the next question, I guess, following up on that, we might have touched on it, is could you comment on how to collect samples for central line absolute bacterial bloodstream infections and catheter-related bloodstream infections? I guess you touched on it briefly, just in case I wanted to confirm this could be a bloodstream or catheter-related central line infected, bloodstream infection. How would I collect samples to confirm this? Or which samples would be necessary to take?
So for the catheter, central line catheter samples, there are two samples that can actually get. As I said earlier, you need to often get a sample, which is often a swab around the catheter tip. Two things happen. If you can actually access the catheter itself, well and good. But at times, scenarios are and you cannot actually get the catheter. So you have to aseptically get off a swab from the catheter and make sure you ensure you continuously have an aseptic procedure done around the catheter and get off a swab. But also in addition, you might have to take off a blood culture, which we all know how to take off. Those are the samples. For the urine, still, as I said, you get the urine after the catheter is removed, and then you collect the sample. That is the right urine you should be able to use.
Thank you. Now, one more thing. Could you comment on the reliability of molecular diagnostics? In this ICU patients. I know that, for example, the PCR stock biofire also covers resistance genes for some of these bugs. I'm wondering whether, from your guidance, the microbiologist, the ICU specialist should be confident to run away with what this test spits out in terms of resistance testing.
So the utilization of molecular tests in the clinical care of patients could be useful if they are fast enough to provide point of care results quickly. In some countries, they've been able to create panels of PCR that they're able to detect several kind of resistance genes that could be available. Maybe if you're targeting a couple of carbapenemase resistant genes and you're able to know whether they're actually present. And this oftentimes helps to quickly get the results. But in general, in our setting, the utilization of molecular tests hasn't really gone to that level. We heavily reliant on the phenotypic tests that we are using right now because we don't have those panels that can easily give us reliable results that can be used immediately. But also the most important utilization for molecular tests is more into surveillance and ensuring that the hospitals or the ICUs are able to institute proper IPC measures based on certain information. because we know that the presence of certain clones or genes could mean certain presence of organisms that could actually spread very fast in the ICU that will be more dangerous. So if you're able to oftentimes to do certain, use demonstrators to do surveillance, that could actually help a lot in the units. They also use at times as a way of supporting things like environmental sampling to look at what could actually be happening in the environments of these ICUs to help in the processes of instituting proper IPC measures. But they are not very, very useful for immediate day-to-day care of patients. What is most important is the ability to use effectively culture methods to support treatment.
Thank you. And I guess as I try to let you off, I just wanted to put back the question I asked maybe 3 years ago about the reporting standards for microbiology, so that the clinicians here know what to expect when they send those specimens to the microbiology lab. And soon they expect a preliminary report, and subsequent communication. And what are your requirements from the clinicians to aid you in that process?
So I think what clinicians need to do as the first thing is they should put some more effort in filling out these request forms. Oftentimes the request forms come with very limited information, and we find it very hard to oftentimes support care when you actually discover certain organisms and you actually don't even know at times where the patient is coming from. For example, at times the request forms come in, they don't even indicate the ward, they don't indicate what the patient is suffering from. They're just saying, Katongole Paul, do urine culture, and that's all. And you don't even know, and then you discover someone has resistant bacteria, and there's no way you can actually reach out. So if we have these forms filled in very well, it will actually help. And also the basic things we talked about of ensuring that we have more engagement between the labs and the clinical teams to ensure that that communication really happens. There also the labs, I think, should be able to provide guidance in terms of the requirements routinely through engagements with clinicians onto which each sample, what should it look like, what do we expect, what would cause rejection, the minimum standards for the clinician. And I think for each hospital, this should apply. If it's Mulago, for example, Mulago should be working closely with the Mulago labs or the Makere labs to ensure this happens, and each hospital also to work closely with their respective labs that they work with.
Excellent. Thank you so much, Dr. Katongole. And again, really thank you for all the feeding our points. There will be a lot more similar engagements, so I'll call you up again and maybe your colleagues in micro. Dr. Beatrice Achan, the microbiology skill, and for the chat. I wish just to ask quickly, the case that we had, this patient came in the suspect diagnosis of TJP, ARDS. But the patient first shown before the team could conclude on what exactly the positive agent was, and was covered empirically a number of medications. In our setting currently, which is reliably available in microbiology to help patients suspected of TJP, not the diagnosis. Okay, to help the clinician not to diagnose that patients.
Oh, thank you, Dr. Erasmus. I think this is the second presentation I'm attending where we had a suspected case of TJP, and it wasn't followed up. The other one was a postmortem presentation that Dr. Nachi leads with Dr. Lukande. So I picked some interest, and I've seen it here again, and I think it wasn't followed up. So we don't have this in the lab, but I can tell you at least what what can be done, what we can improve on. So a quick, a rapid test, which can even be a point of care test, is the beta-D-glucan assay, which is similar to a pregnancy test, which we can apply to serum, for example. And this one we can, serum, blood, different. We don't have it. It's a pan-fungal test. Some fungi will not turn positive using this test because they don't have this particular antigen that this test will detect, for example, Cryptococcus. But when we put together the patient's clinical presentations, plus what we would find in the test, we could make a quick, get a quick result. So pneumocystis is quite hard to diagnose compared to other fungal pathogens like the ones Dr. Katongole was describing, where you look at yeast or filamentous morphology and you go on to culture on subroid. Here we would need to use fluorescent microscopy techniques, which we have in the pathology department, which is just below us. But if we had a suspected specimen, it's something we could easily do. This would be a rapid test. At least we could be able to give a result back. There are also issues sometimes with getting the right specimen. So PJP is quite hard to diagnose compared to the fungal elements. And that is why when the epidemiological data is lacking. But the clinical, that's why I picked the clinical history and the underlying HIV infection, AIDS in this particular patient could be a pointer. And if this was brought up, maybe something could have been done in terms of giving the patient, starting the patient on antifungal treatment. That was the comment I was driving at.
Excellent. Thank you. Thank you very much, Dr. Beatrice. All right. We will continue this with specialty collaborations. It's really quite informative. So, in a similar, we're not going to invite our next speaker. Dr. Juliet Bakay is a resident in radiology. Doctor, please, if I got you wrong, I do apologize. You must be asked who are, I didn't ask that before, but she is going to take us through the appraisal of us chest imaging. Specific focus is to help clinicians get a clue on how to go through that CT scan to make sense of the gray and white lines that you see and the different smudges, things that radiologists magically tease out until like, oh, it can be this. So over to you, doctor.
Thank you very much. Thank you very much, colleagues, and good evening. I'm Juliet Nyakake, a second-year radiology resident at Mackay University. I hope you can hear me and you can see my slide.
Yes,
I'm honored to participate in this knowledge sharing. You can hear me?
Yes, the slide can put you up here.
Okay. Yeah, I'm honored to be here today. Thank you for inviting us. Great thanks to the previous presenters for being brief, which will give me ample time. I will take up some of your time. Our radiologists are not great talkers. We like hiding, but I'll give it my best shot today. So we are going to give a brief reprisal of chest imaging. Chest imaging is a fellowship done in radiology. So today I'm going to give you a crash course in chest imaging. So this will briefly be my outline. I'll take you through a brief introduction and some patterns of lung parenchymal diseases. It may not be an exhaustive presentation, but it will give you a great picture of what to look out for. So chest imaging is indicated in various conditions of the chest wall, mediastinum, pleura, diaphragm, airway, and the lung parenchyma, as you all know. And it's very comprehensive, and there are various modalities which we can use. This presentation will focus on the lung parenchymal disease. As I said, it's extremely extensive and we cannot exhaust the entire chest in 30 minutes. My colleague already presented about the pleural disease in a previous presentation, so that will not be repeated. I'll also not talk about lung masses and things like that. I'll just talk about the patterns. So these are some of the patterns that we usually see in parenchymal lung diseases: reticular pattern, honeycombing, nodular pattern, airspace or alveolar opacification, ground glass, and cystic patterns. Some are a combination of the above. So in order to understand the patterns of parenchymal lung disease, we need to understand a brief anatomy of the secondary pulmonary lobule, which is the basic anatomic unit of the pulmonary structures. And it's the smallest lung unit and surrounded by connective tissue septa. So it looks like this, like a hexagon. So it has a terminal bronchioles within it. What is demonstrated in yellow is the lymphatic drainage, which run in the periphery of the secondary pulmonary lobule, giving it its supposed hexagonal shape. It also has blood supply by arteries, and it's drained by vessels through it. So all this is important to know how these diseases spread, and I think you know the pathophysiology better than me. So we shall go right ahead with the reticular pattern. Here, it's basically when we have too many lines. So you see an image which has several lines. So it can be either due to thickening of the interlobular septa or as a result of fibrosis, as we shall see in honeycombing. So this septal thickening, it can be due to interstitial fluid, fibrous tissue, or infiltration by cells in this septa. The septa are made by this boundary of the secondary pulmonary lobule. So you can have smooth or nodular septal thickening or smooth or nodular reticular pattern. So for the smooth one, it's usually seen in interstitial pulmonary edema, which I'm sure you see a lot in the ICU, where we see curly B lines, A lines, and the like on chest films. It can also be seen on lymphangitic spread of carcinoma or alveolar proteinosis, which gives you a bat-wing appearance. I'll show you an example of that. You can also have the nodular or irregular pattern, which can also be seen in lymphangitic carcinomatosis, sarcoidosis, and silicosis. So on your left, you have the a chest radiograph, and on your right, a zoomed image of an HRCT. So on the left, you can see this widespread, so many lines throughout this X-ray. But if I could zoom out, you could see that those lines look like they have grains around them. So such a picture is called a reticulonodular picture because we have nodular reticulations or lines which have dots on them, giving you a reticulonodular pattern. On the right, we have a zoomed image of an HRCT. You can see these septa are thickened, and they have dots on them, dots on the lines. So that gives you an irregular septal thickening pattern. And in this particular patient, they had lymphangitic carcinomatosis. Another form of reticular pattern is called honeycombing. It basically looks like the comb where you get honey from. It can also be classified as a cystic pattern, as we shall see, because it has these parts where honey comes from are the cysts, and the septa are the lines, giving you a reticular pattern. So it's characterized by the presence of small cystic spaces, which are lined by bronchiolar epithelium with thickened walls composed of dense fibrous tissue. And it's typically seen in usual interstitial pneumonia. However, it may be seen in other pathologies. These combs are usually of an averagely similar size, which is less than 5 millimeters. They're usually small, which would differentiate them from typical cysts. And they're usually clustered in a row or stacked, as we shall see an image. And they are relatively thick-walled, between 1 to 3 millimeters, and they're usually first seen adjacent to the pleura, especially in the bases. So this is a chest radiograph of this patient. In most of the images I'll show you, it will be the same patient. So in this radiograph, you can just see coarse reticular opacities. You will not be able to make any clear conclusion from this picture, which gives us the importance of ordering for the right investigation. I know in the ICU, you mostly have the portable chest X-ray. So depending on what you see on the X-ray, it may, if it has not answered your clinical question, you can go ahead and order for the HRCT. And it's important to note that an HRCT is not synonymous with a chest CT. The main difference is the thickness of the slice. So an HRCT gives you thinner slices between 0.6 to about 1.2 millimeters. And a chest CT, usually they use about 3 millimeter slices. So for example, if you have any pathology that is 2 millimeters, 1.5 millimeters, you will not see it on a chest CT. However, this will be clearly seen on an HRCT. And it's also important to note that an HRCT is a non-contrast study. So it is safe for patients who have renal impairment. And only one CT is done, unlike a contrasted chest CT where we have to do non-contrast and then scan again with contrast. So the clinician should have that at the back of their mind in order to choose which chest imaging modality to order for. So on the right here, this is a HRCT and axial cut. You can see these numerous honeycombs is layered like concentric all over the lung, right away from the subpleural area throughout the lung. And you can see here where the lung bases. So this is a typical honeycomb appearance. This patient has the usual interstitial pneumonia. We can now go to the nodular pattern. Nodular pattern basically means you have too many dots. So this is just a graphic illustration of what a nodular pattern is. In most cases, small nodules can be placed into 3 categories where we have perilymphatic. If you remember the secondary pulmonary lobule, the hexagon, the lymphatics run around the hexagon. So if you have something like this, it's a perilymphatic distribution. You can have centrilobular, still the secondary pulmonary lobule, a hexagon. Inside that hexagon, you see a dot or dots. That is centrilobular. Then you have random, which are not related to the anatomy of the secondary pulmonary lobule. So I think I don't need to repeat this. So this is an example of a perilymphatic distribution along the pleural lines and along the borders of the secondary pulmonary lobule. On the chest radiograph, in this patient, we saw extensive interstitial opacities with a reticulonodular pattern. However, on the HRCT, we are able to now say this is perilymphatic. You can see it runs along the lymphatic drainage. You can actually, if you able to zoom, trace out even a hexagon. So these nodules are in a perilymphatic distribution, and this patient had sarcoidosis. If you look clearly at the edges of the pleura, you can see small air-filled spaces, which is paraseptal emphysema, which we shall talk about later. So the rest of the lung looks gray. Air is here in this bronchus and also here. And you can see at the borders, you see a similar attenuation to what is here, meaning there is some air trapping around here. So that is a paraseptal emphysema also seen in this patient who has perilymphatic nodules. The centrilobular distribution, I already told you, a nodule is seen within the secondary pulmonary lobule, and this can be seen in diseases that enter the lungs through the airways. Diseases like hypersensitivity pneumonitis, respiratory bronchiolitis in smokers, airway diseases like TB, bronchopneumonia, and it may also be seen in bronchoalveolar carcinoma, although it is uncommon. So in many of these cases, the nodules are ground glass. I will talk about ground glass, but ground glass generally means hazy. So you can see these hazy patterns as compared to this other side of the lung. Then one that people like to say, though they may not know what it means, is the twin bud appearance. So you can see this branch that is flowering. This is basically how they look. So it's also a type of centrilobular nodule where you have an irregular and often nodular branching structure, which is identified usually in the periphery of the lungs as it's part of the terminal part of the bronchioles. And it represents a dilated and impacted centrilobular bronchioles, which can contain pus or mucus. So it's almost always pathognomonic. It can indicate presence of endobronchial spread of infection, like TB, airway disease, like associated with infection, especially those where you have a lot of mucoid secretions, like cystic fibrosis, which is not common in our setting. Less often, it can be associated with allergic bronchopulmonary aspergillosis and asthma, where you have superimposition with fungal infection, and also can be seen in aspiration. So if you look particularly at this, we have this bronchus. Bronchi are supposed to taper towards the borders of the lungs. And you can see here, there's this thickening, which is probably due to mucus accumulation. And then we have this pattern of dots that are branching off from this bronchiole. So this looks like something like this. Hence the name tree in bad appearance. Then we also have finally in the nodules, the random distribution, where the nodules are random compared to the secondary lobules, and they can easily be seen to involve the pleural surfaces, the fissures, but they lack a subpleural predominance as what we saw in the perilymphatic because of how the lymph drainage is. And this usually occur as a result of hematogenous spread of infection, and they can be seen in hematogenous metastasis, miliary TB, in sarcoidosis, and in Langerhans cell histiocytosis. So this is an example of random distribution. This X-ray, you could see these fine diffuse micronodular opacities throughout all the lung fields. It looks like they are very small white dots, which appear uniformly similar in size all over the lung. On this HRCT on the right, you can still see these miliary pulmonary opacifications. They are randomly distributed all over the lungs. However, here you see a confluence, which looks like flowers budding from a tree or leaves budding from a tree, giving you this tree in bad appearance in this section. And the rest, you have these diffuse miliary opacities. So this is just a comparison on how they look on the two modalities. For the airspace disease, it may not be a classification of its own, but it helps us to think of what could be filling these air spaces. So here, history is very important. So the air spaces may be filled by fluid, by blood, by pus, or by gastric contents in cases of aspiration. So in airspace disease, you can have these lobar shadows, you can have a consolidation. So for example, in this case on the left, this is a chest radiograph where we have a larger pleural effusion. You can see our costophrenic angle is obliterated. And we have this, here it looks a bit hazy, but we can still see the air bronchograms through it. So which gives us an idea that there may be a consolidation associated with this pleural effusion. And also on the right, our costophrenic angle is blunted. So we suspected a small pleural effusion also on the right. On the HRCT, we're able to see a left lower lobe consolidation with a telectasis. On the coronal images, which I have not shown, we're able to see features of reduced lung volume, but also you're able to see a pleural effusion here. With this consolidation here, you can still see some air on the periphery, but it's really white out. So this is an example of a lobar consolidation with a parapneumonic effusion. Another pattern of alveolar shadowing is bat wing appearance. So it basically looks like a bat which has spread out its wings. And this can be seen in various acute or chronic conditions, acute conditions like pulmonary edema. It can also be seen in PJP. So PJP will give you a similar appearance to pulmonary edema. So history is very important. And then you can also see it in chronic cases like lymphoma, leukemia, alveolar proteinosis, and the like. So in this case, we have bilateral perihilar bat wing airspace opacity. If you look at the edges of the pleura, you can see lines that are running perpendicular like this. Those are the Calibi lines. And usually we have our aortic knuckle here and a depression, then the heart. That depression is the aortopulmonary window. So when the main pulmonary artery is dilated, it usually fills that aortopulmonary window, and that's why we have the sort of a bulge in this area. On the HRCT, we're able to see a similar pattern. They look like wings of a bat or a butterfly, if you like. So you have this airspace opacity in a central peribronchial distribution. We have smooth thickening of the interlobular septa. You see they are more prominent, but they have no nodules along them. And then it's more in the these septa are seen in both the lung bases and the septa and the base and the apex, sorry. So these thickened septa correlate with these Calibi lines that we saw. So on the X-ray, you would just see lines, and the HRCT makes it even more clear. This is an example of a consolidation, which is also an airspace opacity. In a consolidation, you're still able to see the air bronchograms, which are these dark branching structures that we are seeing here. So this consolidation was bilateral. On the chest X-ray, this is the same patient. You are not able to see any pathology much on the left. However, the HRCT was able to bring out clearly that also the left lung was not spared. I think it's because on this image, this patient was a little bit rotated, maybe because they were too ill, but you can see even signs of volume loss. So the HRCT brings it out more clearly. This patient had diffuse alveolar hemorrhage, and some of the symptoms they can present with, you may see hemoptysis or bloody collections in the endotracheal tube. So their imaging might also have a batwing appearance, or will have these diffuse alveolar opacifications. And this patient had extensive alveolar hemorrhage. So you see these opacifications throughout the lungs bilaterally from the apex to the bases. Then we shall go to the ground glass opacity. The ground glass opacities it's a rather unspecific pattern. It may be seen in several diseases. So it can be either as a result of airspace disease or interstitial lung disease, so it can cut across. However, in order to differentiate, we can look at the location of the abnormality, whether the ground glass opacities have an upper zone predominance or lower zone, or they have a centrilobular distribution. So upper zone predominance, you can think of things like respiratory bronchiolitis, pneumocystis pneumonia. For lower zone, more chronic things like usual interstitial pneumonia, non-specific interstitial pneumonia, disquamous interstitial pneumonia. These are interstitial lung diseases. And then a centrilobular distribution, which I already talked about, in conditions like hypersensitivity pneumonitis, where the patient inhales the pathogen. So in this case, it will be an allergen. So this is an example of ground glass opacity. So on the chest radiograph, as I said, it is not very clear to see some of these things. So in this patient, you could see numerous lines. So you have very many lines which are the reticular opacities. However, you have it more marked in this right upper zone. I don't know if it was talked about in the previous presentation, but in the chest X-ray, we talk about it in terms of zones. So the upper zone The zones are divided using anterior ribs. So from the first to the second anterior rib, that is the upper zone. From the second to the fourth, that is the mid zone. And then below that is the lower zone. So that helps clinicians to communicate in the same language if we demarcate it like that. So in this upper zone, you can see this these reticulations, which are more marked, giving you something that looks like a consolidation of sorts. However, on the HRCT, you can see that there is increased graying or haziness in this area, more dense in the right lung, but really diffused throughout the lung. If you compare this part, this is how a normal lung should look, dark, but the adjacent lung, so this is a different segment of the lung. So you can see the rest of it is gray. So this part is pathological. So it is more marked here on the right side. This part was the only normal side left. So this haziness or grayness is what we call the ground glass opacities. The difference between ground glass opacities and a consolidation is that in a ground glass opacity, you're still able to see the vessels. But in a consolidation, it has totally whitened out the vessels and you're not able to see them. Another variant of ground glass opacity is the mosaic attenuation. It looks kind of like this styling design. So this is used to describe the density differences between affected and non-affected lungs. So it gives you patchy areas of black and white. And then it is now up to the radiologist or the clinician to determine which part is abnormal. Is it the black? Is the lung too black? Or is the lung too white? Which part is normal? So when the ground glass opacities present a mosaic attenuation, you consider diseases like that give you an infiltrative process adjacent to normal lung, or normal lung appearing relatively dense adjacent to abnormal lung, which has air trapping. Because air is dark, when you have air trapping, that lung will look more black. And then the normal lung will be the one that will look gray. So in this case, the black will be abnormal. Or in hyperperfused lung, adjacent to hypoperfused lung, if you have a thromboembolic disease. So these are some of the diseases that can give you a mosaic attenuation. So in order to figure out which part is normal, is it the black or the white? So in this case, it is important to have expiratory scans. Unfortunately, the clinician will not expect to have a mosaic attenuation, and therefore they may not know whether to request for expiratory scans. However, experienced radiographers can be able to identify that during imaging, and they give you both inspiratory and expiratory scans if you're lucky. And also to look at the vessels. So if the vessels are difficult to see in the black lung compared to the white lung, it is likely that the black lung is abnormal. Because as we said, in a normal lung, you should be able to see your vessels well. And if this is the case, there are two possibilities. Either you have obstructive bronchiolitis or a chronic pulmonary embolism. If the vessels are the same in the black and white lung, then you're looking at a patient who has an infiltrative lung disease, for example, pulmonary hemorrhage, where you have diffuse involvement of the lung parenchyma. So this is an example of a mosaic attenuation. Usually when we are doing a chest imaging, we tell the patient to take a deep breath and hold. That is the standard. So this was an inspiratory image. The patient took their deep breath and held. And this is the kind of image that we got. Compared to this, which is expiratory, you told the patient to breathe out heavily, then you take the image. So you're able to differentiate. This gives you a better mosaic pattern compared to this. So you're able to compare. So the mosaic pattern was accentuated after expiration, and you can see some tree in bud pattern, very small, many nodules, which suggest here I would think there's some mucoid impaction in this patient. Excuse me. Another pattern of ground glass is crazy paving. So crazy paving is when we have a combination of ground glass opacities with superimposed septothickening. So these are the pavers. So these are the septa. Remember our secondary pulmonary lobule. So if your pavers are gray and also the lobules are thickened, it will give you like this mesh network of pavers, which we call the crazy paving. It can be seen in various conditions as listed here. I think in the ICU, you mostly see this ARDS, you can see pulmonary hemorrhage, infections. So as you can see, many of these patterns I've so far talked about are non-specific to a particular diagnosis, maybe apart from honeycombing, which is common in UIP. Therefore, it is important for you to provide the radiologist with a comprehensive investigation request so that they can be able to tie up both the clinical findings, the examination findings, laboratory, and what they are seeing on imaging. So this is a chest radiograph. You can see this haziness all over the lung, more marked in this mid and lower lung zones, as I already talked about zones. So here you cannot really conclude what it is, but I'm assuming intensivists will say ARDS, internal medicine may say something else, surgeon something else. But when you do an HRCT, you can see these bilateral widespread ground glass opacities, grayness. If you compare to this part of the lung that is more black, you can see this part is more gray. And then you can see that our hexagons are accentuated compared to here. Here you cannot see any hexagon, but here you're seeing these shapes, polygonal. So that is interlobular septothickening. And then you have a few spared pulmonary lobules, as I showed you here. So you have a mixture of gray and black. So that mixed pattern is what we call crazy paving, gray, black. So it's like pavers of different colors are mixed together. And then you have this interlobular septothickening giving you the shape of the paver. That is what we call crazy paving. And then we have low attenuation patterns, which give you a more black lung or a darker lung. And this can be emphysema and cystic patterns. So these abnormalities that give you airfield lesions include emphysema, lung cysts, and these are some of the pathologies that give you lung cysts. Bronchiectasis, honeycombing, I told you it cuts across between reticulations and cysts. And most diseases which have a low attenuation pattern, they can readily be distinguished on HRCT. So we shall start with emphysema. So emphysema typically presents as areas of low attenuation without visible walls due to parenchymal distraction. So it has several types, and I'll briefly take you through some. So centrilobular, remember when we talked about centrilobular within the lobe, the secondary pulmonary lobule, in the center of its centry. So this is an illustration to show you what I'm talking about. So it is the most common type, and it represents irreversible distraction of the alveolar walls. It usually has an upper lobe predominance and an uneven distribution, and it's strongly associated with smoking. That's why we see it a lot in Langhans cell histiocytosis. So you can see these areas. The lung is not supposed to be black like the trachea. It's like a different shade of a very light gray. But here you can see the lung, and then you see these black cystic areas within it. So that is what we call emphysema. So the lung should look like this, not too gray and not black. So this patient had centrilobular emphysema. You can see that the periphery of the lung is spared. So you have this normal grayness of the lung, and this near the central part of the lung parenchyma is where we have these very many cysts. The other pattern is the panlobular emphysema. This one affects the entire secondary pulmonary lobule. So the entire hexagon will be black. And it usually has a lower lobe predominance, and it's commonly seen in alpha-1 antitrypsin deficiency, and can also be seen in smokers with advanced emphysema. So you can see this is the only lung left. The rest of this lung is destroyed. All the lobules are destroyed and now replaced with air. And therefore you see now this blackness of the lung. Then we also have paraseptal emphysema. As it's named, it's adjacent to the septa, so along. For example, in this case, you can see these hexagonal black lesions along the pleural surface. And it's usually can also be isolated, especially in young adults or in older patients with centrilobular emphysema if it begins spreading peripherally. In younger patients, especially those who have other things like Marfan's, it can lead to spontaneous pneumothorax that is undetected. So they start like this and they're asymptomatic, but with time, this one merges with that, and then they become larger bully. And then they can have a spontaneous rupture and hence a pneumothorax. For the cystic diseases, you can have, they are defined as radiolucent areas or dark areas which have a wall thickness of less than 4 millimeters, as opposed to cavities which are thick-walled. So that is the major difference. Cavities have a thicker wall of greater than 4 millimeters. And these are just some examples of the cystic lung diseases. So in this patient, this is HRCT on both sides. You can see these multiple round and bizarre shaped cysts. Many shapes. This one is amoeba shaped. I don't know what shape this is. These are round, others are big, others are small. And this patient had an upper lobe predominance on the coronal and sagittal cuts. And they had a positive history of smoking. And this combination of findings, this patient was diagnosed with lung hand cell histiocytosis. This was a male patient. This was a female patient. She had multiple cysts that are evenly distributed. You can see throughout the lung. And they also had this pneumothorax. And then this patient had no history of smoking. So that's why I told you history is very important. Both have cysts, but now the history and the distribution of the cysts helps us to differentiate. So this patient had lymphangiomatosis, which is of course a common thing that can be seen in females, in contrast to LCM, which is seen in smokers. In this case, you can see several E-defined nodules. The easiest to see is this one. I'm going to trace it out. There's one here. There's a bigger one here. If you're not seeing it, just believe me that there's one here. So it's projecting over the dome of the right hemidiaphragm, and it appears to have a central lucency. If you look at it, it's not all the same density. Around it looks thick, and in the middle looks like there is some little air within it. And then this is the chest, the HRCT of this same patient, which confirmed there's another nodule here. And this is the bigger one here, which we can see here. There's actually another one here. So this larger one has a central cavity, which is consistent to this lucency in here. And then it is thick-walled. You can imagine this is definitely greater than 4 millimeters. That's why we're calling it a cavity and not just a cyst. So this patient was confirmed to have granulomatosis with polyangiitis on biopsy. And I'll also talk briefly about bronchiectasis. Bronchiectasis is broad, but is basically divided into cylindrical, varicose, and cystic. So a normal bronchiole, as the bronchi keep branching, they keep tapering and becoming narrower, as you can see in this image. However, in cylindrical bronchiectasis, you can see that the diameter is not decreasing. In varicose bronchiectasis, you have intervals of narrow and wide, which usually occurs in conditions of fibrosis. So this wide part is being tagged on by a fibrous band, and then you have a narrow part, another fibrous band, giving you that appearance of like varicose veins. Then the cystic pattern, it's self-explanatory. They basically look like cysts. So bronchiectasis is the irreversible dilatation of the bronchial tree, and the diagnosis is usually based on a combination of findings, for example, bronchodilation. So on average, the diameter of the adjacent artery is supposed to be similar to the diameter of the bronchial. Now, when the bronchial diameter becomes larger than that of the adjacent pulmonary, the arterial branches, then we think of bronchiectasis. It gives you this is a signet ring. So the bronchial will be the ring, and the artery will be the stone on the ring. Yeah. So this is the pattern of cylindrical bronchiectasis. And then you have bronchial wall thickening. Ideally, the bronchial walls are supposed to be imperceptible, but now here you're able to trace out this entire wall. And then you have lack of normal tapering, which I've already talked about. And then you're able to also see these non-tapering bronchioles within 1 centimeter of the edge of the pleura. And then you have, because they are dilated, you have mucus retention within their lumen. And then with time, you can have associated atelectasis or even air trapping. So this is an example of bronchiectasis. This is not a very good quality image. As you can see, there were some motion artifacts. However, I can trace this out for you. If you compare to this side, this is not there. However, there is a structure similar to this here. I'm going to pass my pointer through it. So you have this side and this side. In this very part, you have this side and this side. However, there is increased haziness or grayness or whiteness within it. So we call this a finger in glove shadow. If you put one finger in a glove, it will look something like this. And that is usually seen when you have mucoid impaction in a dilated bronchiole. So that is a sign of bronchiectasis on a chest radiograph. On a CT scan, HRCT or CT scan, it can still be seen. You'll see, for example, here are bronchioles. They have air within them. But on this side, those bronchioles, they are white. They are filled with something. In order to differentiate between a bronchiole and a blood vessel, if it is hard, you can follow the trachea from its branches. And then as you scroll, if you're able to get scrollable images, you can be able to follow and differentiate it between blood vessels. This is an example of a cystic pattern. So this patient had bilateral severe widespread bronchiectasis. You can see this round. And then you can see this tubular structure. This tubular one is cylindrical bronchiectasis. The round ones are cystic bronchiectasis. And then when they have something within them, this is an air fluid level. So they had mucus impaction within, mucus plugging. And then when you also look at the lung, we have gray and black. Gray and black, which is a mosaic attenuation. So in this patient, they most likely had air trapping, giving you the more black, meaning the gray part of the lung, in this case, would be the normal one, and the black part of the lung would be the air trapping with this cylindrical pattern and cystic mucus plugging. So this gives you the diagnosis of cystic fibrosis. It's really a picture of typically what it looks like. Then this patient, you can see they had prominent scarring in this right upper lung associated with volume loss. If you look at in the scrollable images, you could see that these ribs are more crowded than this one. And then you have elevation of this hemidiaphragm. You can see that they are relatively at the same level, which they are usually not. This one usually appears lower. And then, and you have this widening of the bronchioles. Everything looks huge up to where they end. So this is also a traction bronchiectasis because we have something here that has caused volume loss. So the lung has been pulled to that side. But because the bronchi are not elastic, maybe not elastic is the wrong word, the bronchioles have to move with the lung. And then also this part of the lung is also there. So they are fighting over it. And with time, the bronchiole will widen in diameter, giving you this traction bronchiectasis. Those are my references. Thank you for listening.
Thank you very much, Dr. Mutake. The truth is that whenever I listen to a new of the songs, I just showing off because, I mean, look at the great lines you talk about and you're like, oh, you see that not the you see that. Anyway, thank you for making it simpler for us, but it's still quite hard. And I know that we can have questions. And we can always depend on you guys to, make sense of, those gray and whites that appear in the images. So over to the questions. On the chat, you've got 2 questions so far, and people kindly send more questions if any, and also raise your hands. Dr. Cornelius is asking, when you are doing a chest X-ray in an ICU patient on invasive mechanical ventilation, should we perform an inspiratory pause at the time of the shot to improve image quality? I just ask if anyone does it. I don't do it. I just accept some of the limitations of imaging the patient in ICU, thinking of the lines of time. So I don't know what have you had a chance to ask the ICU doctors to probably pose inspiration in when the patient ICU doctor?
If I can try to answer, so in the ICU setting, I don't think, I think in the ICU, since it's an emergency setting, in that case, you take the X-ray as it is, of course, depending on the indication of the X-ray. So if the X-ray will be able to give you a diagnostic picture, even if it's not perfect, I think there is no need to compromise anything else on the patient. So it depends on the indication, I think, of the investigation. In which case, if I might ask, in which case would you want to pause?
Dr. Cornelius, please come in. So I guess the idea is that better exposure would probably reveal more pathology. And if there was a way, even in the ICU patient to optimize the image better, we're just trying to figure out if that's a possibility. That's why the question is formulated. On the ventilator, there are different two phases. There's the inspiratory phase and the expected phase. And if the patient is deeply sedated and depending on the ventilator, or is even paralyzed, then you get more freedom to play the event where you can actually pause, in a certain phase. And if that's necessary to improve the image, that could be practiced. I personally don't practice it. I would probably want to hear from the other intensivists on the group. Dr. Peter Gava, Dr. Figuera, you guys do anything you need to improve the images? Dr. Arthur Figuera? Or it's just the avatar? That's on your chest. Dr. Arthur Mwanje, do you ever consider, a pause on the vent to try to improve the images for these patients? Maybe Dr. Yeah, go ahead, Doc. Go ahead.
So I think from the physics side of it, it would make sense because when you pause in the inspiratory phase, the lungs are ideally more expanded and then you're able to see much better. You have better resolution. So from the physics sense of it, I think it can work. I think it gives you a better picture than when you take an expiratory image.
Yeah, you know that I would also add that when you know the ICU patient, like you mentioned earlier on, your safety is the most important. And you know, these are guys who are hanging on, they're hanging on for you know for whatever support you're providing them. So you know, and the ICU images are really not necessarily meant for the granular and perfect diagnostics, but to see the most overt issues, to assess for procedural things, you know, lines and tubes to place, and maybe an overt thing and vital things like maybe pneumothorax, maybe massive aspiration, but for final diagnostics, perhaps a dedicated image to a radiologist would be helpful when the patient is much more stabilized. So I think I personally, that's my approach. I don't really see the value of trying to take this patient through the steroids or posing the event to, you know, even for 5 seconds just take a shot. And remember that this pose, unless you have now the newer machine that can be programmed, most of them require you to pose onto the, into the button ventilator as the image is taken, meaning that you don't be wearing the heavy, protective gear to make it safe for the clinical, the clinician. I don't know. Definitely, my colleagues have been too busy to respond. So perhaps I see Dr. Yotaro's hand is up. Dr. Fiona, over to you.
Thank you very much, Dr. Erasmus. I think you have pretty much put it very nicely from the imaging perspective. Usually when we are telling the patient, when we're doing all these, first inspire and then pause and then we take the image, your aim is to try and get the best diagnostic quality image there is, because you're trying to pick as much information from this single radiograph that you're taking. So you're looking for the perfect exposure, you're looking for the perfect penetration. So I mean, you're getting your exposure qualities to the T because you're trying to get a very good quality image. But at the end of the day, your patient who you're attending to comes at the top of the list of you trying to get your perfect image. Because if you're having an ICU patient who is probably on a vent, at what point are you going to tell the patient, okay, inspire, hold, and then we take the image? It's literally not practical. And one thing I've also seen with the few radiographs that we get from ICU, it's usually a very specific question. Does the patient have fluid in the lungs? Does the patient have air in the lungs? So we're not trying to pick too much. It's usually you're trying to answer a very specific question for the critical care physician, and most times taking the image as is enough. So I think we put the patient's condition at front line. If the patient is not able to do all the other things that we try to do to get a good quality image, then there's no need to put the patient through all that just because you're trying to get a perfect radiograph. Yeah, thank you.
Thank you very much. Next, Dr. Asimwe, quick one.
Thank you, Dr. Julie, for the presentation. I just wanted to ask, for the tree in bud image, okay. When you see that in your chest CT scan, do you always like confirm, I know that's TB for sure, or it could be something else as well? And how many would you see in your imaging for you to confirm that that's the diagnosis for TB?
Okay, thank you very much, Doc. There was a previous question in the chat where they wanted more clarity in differentiating between honeycombing and crazy paving. So in honeycombing, as I said, they're just small cysts with thickened septa. So those small cysts, they're really small. They are less than 5 millimeters in diameter. And then the septa around them are thickened, giving you the appearance like a honeycomb. However, in crazy paving, we don't have cysts. In crazy paving, we have a mixture of normal lung and abnormal lung, which has a different attenuation. So you have different densities. As I said, for example, you have all of it looks like lung, there are no cysts, but some of it is darker than the other. You have a mixture of gray and white, a mixture of different shades of gray. The lung is not looking uniform. And then in addition to that, you have thickened interlobular septa. So those thickened interlobular septa will outline the secondary pulmonary lobule, the hexagon. And therefore you have some gray pavers and some black pavers, something like that. So that mixed pattern is what is called crazy paving. They are just mixed attenuations, unlike honeycombing, where you have very small cysts with thickened septa. Now for tree in bud, as you can see on this slide, this patient was a typical case of TB. However, tree in bud is not pathognomonic for TB. So here is the list of some of the things. It basically means something has filled those bronchioles. So those bronchioles could be filled by gastric contents in cases of aspiration, endobronchial spread of infection, like TB, it could be pneumonia, it could be just mucus, for example, in cases of cystic fibrosis, in the other case that I showed you. So it could be aspergillosis in like allergic bronchopulmonary aspergillosis. So it is not specific for TB. However, these are the things that should go in the back of your mind. Something is filling that up. So the clinician, you have to tie it up. Could it be mucus? Is it fluid? What could it be, depending on the patient's history and condition? There is no number of tree in bud lesions that you need to see for you to suspect something. Even one is enough, because it just showed you that something has filled those bronchioles. So there is no criteria that has the number of tree in bud lesions that you have seen. Thank you. Any other question?
All right, excellent, Doctor. Yeah, so there may be some questions on the chat that you could kindly respond to as we go. And if you really thought, thank you so much for this talk. So now we're going to our final chat of the day, so that our next speaker is a colleague to most of us. He's been through the game with him for a while, right from medical school. So Dr. Winslas Katajira is a pulmonary physician working with Makerere Lung Institute as a research scientist. He's going to take us through pulmonary endoscopy. You need sometimes look at those lungs. And so this evening, we'll have an idea about how to perform some of these procedures and how to apply them in diagnosis and treatment of patients with lung disease. Over to you, Doctor. Kindly share your slides.
Yes, Dr. Erasmus, good evening and good evening, everyone. Please confirm if you can hear me.
Yes, I can hear you loud and clear, and your slides are clear.
All right, thanks. How many minutes do I have?
Yes,
this as brief.
It's all right,
Sorry?
Doctor. You can do 15, 20 minutes,
Yeah.
but as long as it takes to make the point go home nicely.
All right. Hopefully I'll keep it as brief as possible. So yeah, I probably wanted to limit this to bronchoscopy in the emergency setting and what can be done. I think by now we know that we have both rigid bronchoscopy and flexible bronchoscopy. A lot of advances have happened over the years in terms of innovating around this. And I've just tried to show you some of what you will see. Sorry, let me just try to move away these floating things. Yeah, so what you probably see for most of the more advanced bronchoscopy units is this quite advanced flexible bronchoscope. If you can see right here in the, let me see if I can erase that. Yeah, if you can see right here in the middle, I put for you what you would call the tip of the bronchoscope. And you might probably think it's just a small thing, but it's actually a little bit complex. So you have this instrument, or what we call the working channel. So this is really where you put all your instruments. If you want to do any procedures, they will pass through here, but it's also where you will introduce the saline if you're going to do the bronchoalveolar lavage. And then on either side of it, you have wires that will respond to the movement. When you press here on the rotating range, as you press down and up, you basically are activating these wires to turn the bronchoscope up and down. And then you have two those blue side things are the light fibers. They are two to really support. So just in case one dies, you still have some bit of light to navigate. Usually when both of these die, that it spells the end of the bronchoscope. Just discard it, because without a light, working light, you really can't do proper bronchoscopy. And then you have that image guide. That image guide is really what has the video, and you can also take pictures. You can take still pictures that you can later. I think you've seen those. You've seen reports of the bronchoscopy that has still pictures. So that's really where that happens. And then down here, you have another connection that really now takes the entire thing to a light source and in onto the video, like onto the TV. So most of the time, I didn't put the earlier bronchoscope, so I had to put the eye, next to the scope, like on top of the scope as you navigate through the airways. But right now it's a bit advanced, so you really just navigate as you are seeing everything on the TV. So that's really, in summary, what you will see. I will probably not go through all these parts. They'll probably become more relevant when you're going to perform one, and you will have to go through what you have to do with each of the buttons. So that's, in a nutshell, is how a flexible bronchoscope would look. And you introduce it through the airways. And we will have two routes. You can use the nasal route or the oral route, or what they call the mouth route. The nasal route is preferred for most bronchoscopists because when you use the nose, by the time you exit through the nasal spaces, you are just really staring at the vocal cords. So once you see them, and in a way, the nasal route helps to stabilize the bronchoscope. So the moment you pass through the nasal cavity, you really see the vocal cords right there, and then you just introduce the scope through the vocal cords, of course, after applying some lidocaine.
Yefumba naye tugenda mutwalire tumuwekeyo.
Hello. Anyway, so the nasal route, its only underside is the high risk of bleeding, and it's because of that when the patient's platelets are less than 50,000 or below, usually it's no longer a safe procedure. So usually the advice would be to try and transfuse with platelets to build those numbers up before you attempt the procedure. Why? Because of the high risk of bleeding and epistaxis. The mouth route is more comfortable for patients, and most bronchoscopists actually will use that. And by and large, it is associated with less bleeding risk. And this we will not probably have enough time to go through the entire anatomy and how you will see, but by and large, the right side is the most interrogated part of the airways when it comes to bronchoscopy, mostly because its branches are really right immediately there. So the moment you go in, and you kind of on the right, you start seeing all the areas that you want to go and interrogate. So for most people who are just doing sampling of the airways, just doing a basic bronchoalveolar lavage, they will always go to the right. It is very easy. And when you introduce your saline for the bronchoalveolar lavage, it will come back very quickly. So the yield is very good compared to the left side. But yeah, so this is really the summary of how it will look like. This is the bigger airways from the trachea to the two principal bronchi, and then the right and the left main stem bronchi. And then, of course, as you go down, they start to go a bit, become a bit smaller. So there are 5 things that we can do with the bronchoscope. You can do a bronchoalveolar lavage, which is basically what I've been talking about. Those usually will help to doing do many things. So you can do investigations, culture, sensitivity, to look at which infections you're looking at, but also in interstitial lung disease, you can do a bronchoalveolar lavage, look at the cells that are in the airways, and then you can have bronchial brushing. The brush usually is helpful when you have endobronchial tumors. So you just brush, and then you pull it back into the working channel, and then you pick those cells and take them for histology. You can also do a transbronchial needle biopsy. This is mostly for lymph nodes that are around the airways. So here you really you have to first of all wedge and stabilize the bronchoscope, and then introduce the needle, and it has to pass through the wall of the bronchus, and then you sample the lymph node, aspirate, and then you take it out. You now pull back the needle and take that for analysis. The endobronchial needle aspiration mostly is for things within the airways. So this could be pus, it could be anything that is infection related, and you just really just aspirate and take whatever it is that you've gotten and put it to the lab. And then you have biopsy forceps. Most of these are alligator forceps that will really go in and bite whatever it is that they're seeing. Mostly these are masses within the airways. This is really associated with very high bleeding risks, and for safety purposes, once the thing looks a bit bloody and red, most people will not want to biopsy unless they really have an entire team ready for the worst case scenario. So most of the time, once they see that, they'll probably just take pictures and then try to see if they can find an area that they can biopsy that is not bleeding, and then take it out. But for advanced centers, when they do that, they will also have other medicines that actually help to arrest bleeding as soon as possible. So for advanced centers that have, all the medicines and very excellent teams that have handled this before, this can be done. So most of the time, most of the centers in Uganda, you will find actually are very comfortable with bronchoalveolar lavage and maybe bronchial brushing. The other things are a bit advanced and require, I think, more preparation, but also even the supplies, getting the supplies is a bit difficult. So for the alligator forceps and just biopsying the endobronchial masses and tumors, that usually is associated with bleeding, and you have to really be ready for arresting that bleeding as soon as possible. Now, I will probably sorry, the slides are not moving. I'll probably move to maybe the 5th indication, which is, I missed the big chunk of the case, but I found at the very end where I think there were suspicions of injury and possible emphysema. So one of the things actually that can be used for bronchoscopy, let me see. Yes. So you can actually use it to diagnose endobronchial injury, as it is actually regarded as the gold standard when it comes to assessing and confirming bronchial injuries. Because you really be able to visualize where the lesion is and be able to grade it. And because when you grade it, then you will know what kind of management modalities that you will be able to enforce. Now, if we go and see, here you see the levels, and then you can see what you can do for each of the levels. So most of the level ones are superficial injuries, and usually those are managed conservatively. But when you go to level 2 and level 3, you really have to be on standby for anything, because for level 2, these are usually deeper and involve the submucosal layer, may present actually with mediastinal emphysema as well. Though those occurrences are less compared to level 3, which usually involves complete transmural tears, involving all layers of the airway wall. And these usually will cause significant air leaks and emphysema and things like that. So if you want to really know what you're exactly dealing with, then you really might do that. But you will also talk about the contraindications, things that you have to consider before you do bronchoscopy to make sure that such a patient who has probably sustained such an injury is safe to undergo bronchoscopy. I know that there are times when you cannot probably do bronchoscopy. I know there is room for radiology where they can very carefully and slowly investigate, especially these more advanced injuries, especially level 3, and maybe some level 2, where you really can see the damage to the air wall, the airway wall, and probably be able to recommend intervention, probably by cardiothoracic. Yeah, so there is room for bronchoscopy in these cases, and indeed, where possible, this is considered the gold standard. There are other cases. I think I talked about bleeding. That should be probably, yes. So for bleeding, I think I talked about this. You can still do therapeutic bronchoscopy, where you can introduce all saline lavage to induce vasoconstriction, but you can also, where available, you can also do balloon tamponade to block the bleeding vessels, and then you can also use conexalic acid and just irrigate the areas where the bleeding is coming from. So I think this is what I was talking about when if you're going to do an alligator forceps biopsy of the airway mass, then you also have to have these modalities that can arrest bleeding in case it were to happen. And then the other indications, of course, the first one is airways. You can help to clear most of the plugs. Sometimes we've seen patients who have extremely thick, very, very thick mucus. And when you really pull it out, it comes out as a very thick strand that actually is causing air obstruction and hypoxia. And in that case, you can, if you have the right supplies, the right material, you can actually use bronchoscopy, introduce what you need, especially the alligator forceps, identify the that thick mucus secretion blocking the airway, and then you pull it out gently, and it can come out and relieve the air obstruction. But also, for some of the patients who might have a lot of mucus secretion, you can do pulmonary toilet, where really just go in and suction. Most of the time, you really do a saline lavage and take out most of the excess mucus that is causing issues with the airways. And of course, these people, if you don't intervene quite early, you can actually cause ventilator dependence. So the moment you take out those things causing airway issues, then you will wean them off earlier. Yes, and then I think we talked about that. So there is room for using bronchoscopy to intubate the patients, especially where you anticipate difficult intubation where you have facial, inhalational burns, inhalational injuries that will cause airway edema. You can actually use, so there are these bronchoscopes that are single use and are designed actually for intubation. An example of this is the Deflex 5.0, which can accommodate endotracheal tubes that are 6 millimeters or larger. And you really, all you do is attach it, attach and put it in place at the top of the bronchoscope, connect to the videoscope, and then you, as you introduce and enter, introduce the bronchoscope and enter through the airways, you actually then introduce the APT, secure it by ballooning, and then you can now remove the bronchoscope. So most of the time where you anticipate very difficult intubation, especially for people who have airway edema from inhalational burns, there is room for this, using bronchoscopy to introduce the endotracheal tube. All right, I think that's also done. So for trauma, we finished that one. And then for infection, I think Dr. Katongole mentioned this and talked about this. You can do bronchial lavage to make a diagnosis. And I think we talked about, I had some people asking about it. We now have BioFire, the pneumonia panel, which of course would best. I think the diagnostic field is better if you're using bronchial lavage, because that then gives you a very good quality sample. But you can diagnose all manner of pneumonias, TB. You can also diagnose PJP as well as other fungal infections and viral infections if you get a very good bulk sample. So among the contraindications, of course, you always have to identify patients at risk of decompensation during the procedure. There are some indications that are considered to be absolute. So most of the other contraindications that were so many have now become relative contraindications because the centers have become a bit advanced and are quite excellent in intervening and mitigating some of the complications that people fear. But severe refractory hypoxia is considered to be an absolute contraindication, especially if the patient will not be able to maintain adequate oxygenation during the procedure, or if for any reason or another, your equipment that delivers oxygen is malfunctioning. If any of that happens, then you really don't. And that's why you see part of what like people check in the endoscopy list is that they have not just an oxygen cylinder, but they have also a spare one because anything can go wrong. Of course, the cases here that we probably will be a little bit outside here, that will be up for discussion, is where the cause of the hypoxia is actually causing oops. Please confirm that you can. I got disconnected for a bit.
You can hear you now.
I'm sorry?
Okay. You're well connected, doctor.
Oh, okay. There's an incoming call which disconnected me. Yeah. Yeah, so there's cases where actually the cause of the severe hypoxia is a foreign body. And in that case, bronchoscopy in this case would be therapeutic. So then you have to assemble a team and anticipate complications and then be ready for them. And then the other is for patients who are intubated, you know that you probably will be able to handle any of these things should anything happen. But for those who are not intubated, so for example, there are some centers that will specifically intubate the patient for purposes of bronchoscopy. But of course, there has to be consideration of the possible complications that will come out of the procedure. And that discussion usually is held with the patient to tell them, and they still have to consent to intubation if it would make bronchoscopy a bit easier. And then so thrombocytopenia is another absolute contraindication. So even for experienced centers, if the platelet count is less than 30,000, no one is going to touch that patient. For less experienced centers, 50, 50 is the cutoff. But even then, like they really want to probably transfuse you a bit before they go in, unless it's an emergency. Now, when it comes to the nasal route, you remember that we talked about it is associated with high rates of epistaxis. So those ones, it's a no-go area for platelets less than 50, because again, of the high risk of bleeding, from the procedure. Then for unstable or severe obstructive airways disease, patients with acute exacerbations of asthma and COPD, the overall people would want to be sure that they are as stable as possible, because they can very rapidly become decompensated and make the whole procedure quite unenjoyable. And then for hemodynamic instability, myocardial ischemia, so anything that is going to cause significant hemodynamic instability, whether it is recent recurrent myocardial infarctions, poorly controlled heart failures, significant hypertension, then the later stages of pregnancy that will compromise on the hemodynamics of the lungs, then bradycardias, tachycardias, life-threatening cardiac arrhythmias, severe PHT. These ones, once they are there, these patients are at risk of very rapid decompensation, and they can go downhill very rapidly. So I'll probably end with this slide and see if there are any questions or comments.
Thank you so much, Dr. Katajira, for this talk. I know that we had you rushing through it, but this is quite informative and definitely good stimulation for further study, hopefully even more interactions where you might have a chance to instruct a number of members of this crew. So the one question I'm seeing on the chat really is about that. Where can I learn the use of flexible bronchoscopy?
That's $1 million question. So I think what you need, so we have been lucky at the Lung Institute that we have experts from the University of Washington that actually periodically come and train. These are guys who are very, very experienced trainers, and they usually before they come, they will ask to book patients, both the difficult ones and the easy ones. And then they will really come in and you just go through that. So you need, number one, patients, then you need experienced trainers, and then you need time. So for example, even now, Dr. Rudy actually, I think would be willing to really have you shadow. However, his bronchoscopies are done at 6:30 in the morning. And usually by about 6:45, he's done. So I think that's really where the issues with this, and the more patients you have, of course, the better you become. So the training is both theory training, where you know everything about bronchoscopy, airway anatomy, and contraindications, all those things, and all the medicines. Of course, it wouldn't be very difficult for the anesthesia people, because you know all these medicines that we use in bronchoscopy, side effects, what to look out for, how to correct the side effects. And once the theory is all done, so the next is really hands-on. So the other thing is you always first start by practicing on the dummy. So usually there are those practicals where they would put, for example, a very small bean pod in one of the most advanced airway segments, and then they will tell you to go for it, and you have to tell them all the structures that you're going through. And sometimes what you would say I didn't, let me see if I can do that. So there is a more detailed bronchoscopy anatomy that, are you seeing that B4, B6, B8, B10? So they will probably just put, they will tell you we'll put a beam in B10. Then that's how you're going to go there. So because it's really that airway anatomy. And then after that, it's now about practice, and more practice. And once, because it's a skill, and once you're comfortable with it, you can do your bronchoscopy.
Thank you. Maybe just to supplement on that also, we do have, a bronchoscope that I use at our facility at TMR, and so far we use it for difficult intubations, but also for specimen collection in some difficult to diagnose patients, as well as bronchopulmonary toilet. This would be a quick, quick and dirty on its use on some of the patients. So if there is anyone who has got some of these complex patients, for sure we can definitely arrange to just have an orientation to it, and maybe have a few hands laid on it so that you get a feel of how it goes. Yeah, so thank you. Any other questions, gentlemen and ladies? Okay, I see a question from Patrick Semakula. Could you just unmute and ask you? You basically put in rigid bronchoscopy and put a question mark. Dr. Patrick Semakula?
Yes, thank you. I just wanted to ask, like, where does it lie? Like, maybe for him to just simply hint about it, talk about it a little.
Okay, Dr. Katajira, I think the question is, if we were to perform rigid bronchoscopy, how would the image be like, or where would it lie? That's the question he's asking.
Okay, so maybe to simplify what rigid bronchoscopy is, it's basically, just imagine it's rigid, so it's like a pipe that you can use to visualize the airway. And it's mostly the ENT that actually use it to really try as much as possible to retrieve foreign bodies. The flexible bronchoscope has an advantage of being able to go through most of the airways, but the rigid bronchoscopy can't. So for example, probably the farthest that you can go in the rigid bronchoscope is the trachea, because it really can't go into the principal bronchi that now take off at an angle of like 25, another one goes at like about 6 or something like that. So I think that's the biggest difference between the two. So most of the rigid bronchoscopy will be in the ENT departments mostly, and to help retrieve foreign bodies, especially those that are stuck in the big airways. Either in the trachea, at the carina, the main carina, or what some people call carina. And then maybe those, for example, coins that might wedge in the right, probably at the beginning of the right main brainstem bronchus, or the left, probably those ones you can. Otherwise, for those that are a bit deeper, we can then use flexible bronchoscopes.
Thank you so much, Dr. Katajira. Maybe just to add to the use of the rigid bronchoscope also, especially for the critical care doctor and emergency physician, is the aspect of double preparation or double setup for difficult airways. So occasionally we receive these patients who are predictable with difficult airways. Maybe they have got epiglottitis or something like that, or have got an airway tumor, and there's a likelihood that sedating them may make you lose the airway. There are such patients where you have a double setup or even a triple setup where you have the regular, intubation prepared, but there's also a possibility of setting up a rigid bronchoscope with ENT on standby alongside possible setup for a tracheostomy in case things go haywire. So just to add to this, I see also Dr. Mary has added a bit of a bullet here on how to train oneself on bronchoscopy. So she says there are apps that can help you with practice. Airway X is one. So Dr. Eddie and the rest of the crew, that will be a nice area to look into. So we are gone past our time, and I would like to thank Dr. Katajira for waiting and also delivering this talk to us. So I would like to start edging us towards the conclusion of this evening. So we've been covering this cross-specialty diagnostic consultation, and I hope that at this point now everybody understands the addition of the other specialties to our diagnostics in patients that we care for. Remember, microbiology is probably misused. We probably don't know how to then draw the samples safely, how to protect them. We don't probably take the right specimens at the lab, and we probably would benefit better from including microbiologists in our day-to-day activities regarding diagnosis. Just put a phone call across and ask them what could be done, or which test would be more helpful in matching what you want to do. So they are very helpful in guiding you direction and the choice of diagnosis and therapeutics as well. When it comes to imaging, as usual, these guys are wizards. I mean, they see things. You look at the same CT, and then the radiologist comes saying, "Oh, it's this disease," and no, it's just so magical. Certainly, as per this evening, a 3D image always gives a lot more detail, a lot more information to our patients. I think, especially for the critical care setting, try to always use that 3D image as much as possible. It helps a lot. And then it also helps to peep into the airway, and selection of patients is key because, as Dr. Katajira told us, there are situations where the performing bronchoscopy could be risky. Maybe patients got refractory hypoxemia, and just interrupting the airway just a small bit could actually be deleterious. So, but otherwise, imaging the airway directly through or indirectly through a fiber optic, read bronch, and other things that you could not talk to us about because of the issues of time, would be very helpful in therapy and also diagnostics. I know you didn't go into things like endobronchial ultrasound and other things that are transbronchial biopsies and the like. It would be quite fun stuff. These guys do magical things and really make a difference to our patients. So I'd like to thank you so much for hanging on. We are almost an hour past our usual stopping time, and I would like to introduce a topic for next week, which will be taking us back to the cradle. We'll be looking at the baby, and we shall be having baby doctors taking us through that. So tell a colleague to tell a colleague to tell a colleague, and join us and have fun. Thank you so much, and I wish you a great weekend and a happy new month. The month of love is over. Thank you, and bye-bye.